So today our video is going to be about odontoid fractures, what they are, their classification systems, and the different treatment options that we have for them. The topic came up because I recently saw someone in clinic with an odontoid fracture. This one 6 months down the track, and thus go into a little bit about sort of post-care and evidence of non-union and options from there as well at the end of the video. If you guys have any other topics that you want to hear, chuck it down in the comments. So we'll start off with some general information. So what is an odontoid fracture? So it's a fracture of the cervical spine. We've got the body of the axis, the C2, the atlas is C1, and you can see there's actually two fractures here, but the one we're going to be focusing on is there's an odontoid process of the actual axis body, and there is the fracture line itself, if you can see the mouse. So a little bit about the axis. So this is the second vertebral body, second cervical body. So you can see that this is the top view and this is the view looking from the back. So you got the dens, that's like a little pointy bit, and it's a fracture pretty much of the dens. There are different four ways and classifications of this fracture. And it's really important because the dens is a place of attachment of many different ligaments that help support the cervical spine. It's about 10 to 15% of all cervical spine fractures. It can happen in the young and in the elderly as well. So in the elderly, even after minor trauma, if they've had a fall, hit their head. But in the younger ones, it usually involves major trauma, so car accidents or fall from a significant height. Some of these fractures can be fatal at the time of injury, just because if you imagine, you've got your spinal cord and brainstem, and thus risk of injury to those structures can be quite fatal. Flexion, so usually the patients are usually flexed at the time of their injury, and they usually have anterior displacement of the C1 to C2 called atlantoaxial subluxation. So what are different signs and symptoms? So 25 to 40% can be fatal at the time that it actually occurs. So 82% of these type 2 fractures, we're going to go into the different types of these fractures a bit later on, but just know that the type 2 is the most common type of fractures, and 82% usually have no neurological symptoms. They're usually all intact. 8% have very minor deficit like sensory changes down their arms. 10% had very significant deficit, so monoparesis, unable to move one limb, all the way up to quadriplegia, so unable to move arms or legs. Type 3 is rarely associated with any neurological injury, which is good. Here's a picture of a random person holding the back of their neck, but most common symptom is actually just high posterior cervical neck pain. They can have a bit of muscle spasm around the site. And then later down the track, if the fracture never actually heals, they can have myelopathy, which shows that there is compression or injury to the spinal cord, and they can have sensory changes, weakness in their arms, legs, and their walking, and can lose their bladder and bowel function. This is all longer term. So next thing, we'll go through the different classification systems. So you can see nicely type 1, you can see it's just involving the tip. Type 2 is sort of at the base. Type 3 actually involves the body as well. And they all influence how we treat them and their prognostic outcomes. So type 1, so if you imagine the actual dens, the pointy part of the actual axis, is a place of attachment for a lot of major ligaments. It's very rare. This if it just involves the tip of it. So type 1's very rare. Risk of injury, it really depends if there's involvement of the actual transverse ligament, because then that can lead to atlantoaxial instability, and that would prompt treatment. Type 2 involves the base. These are the most common type of injuries, and they're very high risk for non-union, so they tend not to heal sometimes. And often they would actually require surgery to prevent instability. Type 3 extends down into the actual body. You can see it can be misleading. So if you see it from the CT scan on the side-on view, this looks like a type 2, but then when you look at it from the front-on view, you can see it actually involves the body. So it's really important to look at it from two sides of the angle. So they're generally considered more stable. They're quite favorable in their healing prognosis with the appropriate treatment in place. So how do we treat them? So things to consider. If it's an isolated type 2 fracture and the patient's age is more than 50, we should consider a form of surgery usually because they all elderly people or tend not to have great outcomes in terms of healing when we manage them non-operatively. If it's non-displaced, so if the fracture, this one's obviously displaced, you can see it's displaced away from its original location. But if it's not displaced and it's well aligned, you could consider immobilization. So I'll talk about how we immobilize patients without surgery. But if it has displacement of more than 5 millimeters, if there's comminution, which means fragments of the fracture, or if you've tried immobilization and you're just unable to achieve good alignment, then it's all indications that you should probably consider surgery to fix it. So these are ways that we can manage them without an operation. So there's two ways, halo vest and a cervical collar. So of course, cervical collar compared to a halo, less distressing, more comfortable, but you can see has a 53% fusion rate of the actual fracture. And we all know with cervical collars, they do have good stability for mid cervical fractures, but when you're looking at fractures higher up, they don't tend to protect those areas very well. And same with the ones very lower down as well. Halo vests, so these are a vest strapped around your body. It has bars and it has screws that are pinned into the actual skull itself. Very uncomfortable to place on initially, and it can be very uncomfortable whilst they're on, but it's a much better form of fixation or external stabilization compared to the collar. You can see this guy's not very happy. This guy's semi-happy. Surgical options, there are two ways, odontoid compression screws and C12 arthrodesis. So I'll go through the two different approaches. So I guess odontoid compression screw is when you're using a guide wire and putting a lag screw into the actual odontoid. So you can see that you make a transverse incision going through the muscles and exposing down where you can put a wire through and then guide a screw to actually help fuse the fracture. It can be very good when it's like a type 2 fracture and the transverse ligament is still intact and attached. And you can see that this the patient after the operation, post-op X-ray showing good location of the screw. So C12 arthrodesis. So this is a form of fusion. This is from the back approach, so going through the back. Different options. You can do wiring and fusion, transarticular screws or Halfix clamps. And often, here is a picture of a lateral mass screw where you're using screws into the C1 and C2 and using as a form of fusion and just preventing any mobility. Of course, you can imagine that this would limit their to a degree about the amount of flexion that they can perform. And during the operation, it's very important to identify major arteries, like the vertebral arteries here, when placement of the screws. And then finally, non-union. So if you're doing like a non-operative management of these sort of fractures, the risk is that they sometimes don't heal and they form something called non-union. Usually they present with ongoing neck pain even after the brace is removed. So if it's a halo or a neck collar, and the issue is that because it's a mobile piece and it has non-union and due to some motion as well, and sometimes soft tissue sort of start proliferating around the actual region, it can then start to impact the spinal cord and then cause myelopathy in about even up to 77% of patients, where they can have progressive deterioration in their hand dexterity, their muscles, their walking, their gait deterioration, and then it can impact bowel and bladder symptoms as well. So that's an overview of odontoid fractures. Hope that was helpful. If you have any sort of suggestions on what you want to see in the future, let me know. Don't forget to like and subscribe, and I'll see you guys next time.